So treatment of vaginal carcinoma depends primarily on histology, tumor volume, anatomical location, disease stage and patient's age group. Due to the tumor's location, treatment can impact reproductive potential in younger women and sexual function at any age. So management options include surgery, radiotherapy or combination of some or all of the above. Surgery. It plays limited role in treatment of primary vaginal cancer due to close proximity of the tumor to bladder, urethra and rectum. Typically, surgical intervention is reserved for early stage lesions and small size, that is confined to vaginal mucosa only and less than 2 cm. There are no RCTs supporting its use and most of the literature consists of retrospective studies. However, surgery may have a role in select cases beyond early stage disease as outlined below. The role of sentinel lymph nodes in vaginal cancer has not been established yet and cannot be recommended. So sentinel lymph node is not used in vaginal carcinoma. Surgical management in stage 1 disease, that is early disease. You have to check whether there is upper vaginal disease or lower vaginal disease. In upper vaginal disease, the tumor is limited to the mucosa, then it is stage 1 disease. If the uterus is in situ, then radical hysterectomy, vaginectomy, aiming for 1 cm disease-free margin and pelvic lymphadenopathy should be offered. If the uterus has been removed, then radical vaginectomy as above with pelvic lymphadenopathy can be performed. Whereas in lower vaginal disease, radical wide local excision with 1 cm margins can be offered in addition to bilateral groin node dissection, because in lower vagina the lymph node dissection is bilateral groin, whereas in upper vagina it drains to pelvic lymph node. Ovarian transposition during surgery and before radiation. In young women with vaginal cancer requiring radiation as the primary treatment, ovarian transposition can be offered before definitive radiation treatment in an effort to prevent the adverse effect of radiation-induced menopause. In certain cases, laparoscopic or extraperitoneal removal of bulky lymph nodes can be offered as part of staging and treatment planning. Central recurrence after radiation treatment. Pelvic exentration is a possibility if the recurrence is central and isolated. These patients require extensive counseling regarding the risk and morbidity of the surgery, as well as the impact on quality of life and body image. Palliative management of recurrent or advanced disease. In women with advanced, that is stage 4 disease or recurrent disease who present with vesicovaginal or rectovaginal fistula, a palliative urinary diversion or colostomy can be offered to improve quality of life before definitive management with radiation treatment. Radiation. In majority of cases, particularly in advanced stage, radiation constitutes the cornerstone of treatment for this disease. This is a combination of external beam radiation and intracavitary radiotherapy or brachytherapy. The principal advantage of radiation is organ preservation. As in other pelvic malignancies, MRI has become an essential component, properly defining tumor volume and the spatial relationship of the tumor with neighboring organs during the treatment planning. EBRT to the pelvis includes the external iliac and obturator nodes as per the standard of care. In addition, the inguinal nodes may be included if the tumor is in the distal vagina. Brachytherapy is used to deliver a boost of high-dose radiation to the residual tumor, and the use of brachytherapy is associated with longer overall survival. Image-guided or adaptive brachytherapy using CT or MRI allows for the delivery of higher radiation doses to the residual tumor while minimizing exposure to surrounding healthy organs. The optimal or lower threshold dose is 70 Gray, which has been shown to improve outcomes. Doses higher than 70 Gray result in significant grade 3 and 4 toxicity. IMRT, that is intensity modulated radiation therapy, is an advanced form of radiation that enables the delivery of higher radiation doses to the tumor. Although studies in vaginal cancer are limited, IMRT may allow improved doses to the cancer and reduce adverse effect by sparing the adjacent organ from radiation. Concurrent chemotherapy with radiation. Modern management of vaginal cancer often combines concurrent chemotherapy such as cisplatin or 5-fluorouracil. This has been extrapolated from the successful outcome of this treatment with the cervical cancer. However, most studies using chemoradiation in vaginal cancer are limited owing to small number of cases and lack of comparison to radiation on its own. The combination of EBRT and brachytherapy to a total dose of 70 to 80 gray with concomitant weekly cisplatin based chemotherapy is the current standard care for locally advanced vaginal cancer. Chemoradiation may be considered in the treatment of vaginal cancer following a 2013 retrospective review suggesting a potential improvement in overall and disease-free survival. Although this was a small review of 71 patients, it showed a significant difference between both overall survival and disease-free survival when comparing women who received radiation alone versus chemoradiation as primary treatment. 3-year overall survival was 56%, whereas 79% in chemoradiation, and 3-year disease-free survival was 43% in radiation alone, whereas 73% in chemoradiation. In addition, a large American-based National Cancer Database study supported that it was found that concomitant chemoradiation was an independent prognostic factor for improved survival. So treatment pathways for vaginal cancer stage, you have to look at whether it is localized tumor, that is no deep tissue involved, locally advanced disease, that is paravaginal tissue involvement, and size can be of more than 2 cm, or metastatic disease. If it is localized tumor, you have to check whether it is upper vaginal disease or lower vaginal disease. Localized tumor with upper vaginal disease, then check whether the uterus is intact or not. If uterus is intact, then radical hysterectomy with bilateral pelvic lymph node dissection and vaginectomy with 1 cm margin. Uterus is absent, then vaginectomy with 1 cm disease-free margin and bilateral pelvic lymph node dissection to be done. In lower vaginal disease, lower vaginectomy with 1 cm disease-free margin and bilateral groin node dissection to be done. In locally advanced disease, that is involvement of paravaginal tissue, radical concurrent chemoradiation therapy, that is EBRT and brachytherapy. This treatment is similar to advanced CA cervix. In metastatic disease, you have to check the performance status. If good performance status, then palliative chemotherapy, and if poor performance status, then palliative supportive care to be given. So when patient comes to you, full pelvic examination and examination under anesthesia is required. If vaginal lesion touches or involves the cervix, then primary vaginal cancer is excluded. It diagnosed as CA cervix. And vaginal lesion, cervix normal in appearance and tumor does not touch the cervix, then diagnose it as vaginal lesion and do the biopsy to confirm the cancer. That is histopathology is required, and you can do HPV DNA typing. And in staging investigation, blood test, chest radiograph and CT of the abdomen and pelvis. In high income settings or where available, can consider PET CT scan to assess nodal disease. If no metastasis, then MRI to assess deeper paravaginal tissues. You have to check whether it is suitable for surgery or not. If small lesion and no deep tissue involved, then she is suitable for surgery. If she is not suitable for surgery, then chemoradiation is the treatment of choice. Special situation like adenocarcinoma, melanoma or sarcoma botrytis of vagina. Adenocarcinoma of vagina. Primary adenocarcinoma of the vagina accounts for 8 to 10%. In 71, Herbst et al. Described the association between diethyl stilbecell and clear cell adenocarcinoma in doctors who had intrauterine exposure during the first 16 weeks of pregnancy. Most of these cases were diagnosed between the age of 14 to 20 years. A 2017 retrospective review of 420 cases found that most cases were in younger women, but there was a small second peak at around 42 years. So intrauterine DEC has been banned since 1970s, and it is expected therefore that clear cell adenocarcinoma attributable to intrauterine DEC exposure will disappear in the coming decades, as there is no more intrauterine DEC exposure. For women with known or suspected in utero exposure to DEC, closer follow-up is recommended. This includes annual cytologic screening of the so-called 4-quadrant cervical smear test with extensive sampling of both cervix and vagina, as well as careful visualization of these areas. So colposcopy and Lugol's staining should be used whenever there is clinical suspicion. In addition, DEC doctors should undergo mammographic screening due to slightly increased risk of developing breast cancer. Non-DEC adenocarcinoma is exceptionally rare and behaves as a different entity with a different natural history. This may include endometrioid arising from endometriosis or mucinous subtypes, which are typically diagnosed in postmenopausal women. Treatment is most adenocarcinoma are treated in the same manner as the squamous cell carcinoma. Vaginal melanoma. Vaginal melanoma is exceptionally rare and is typically diagnosed in the elderly women. The incidence is approximately 3 per 10 million women. There is no established standard of treatment for vaginal melanoma due to its rarity. However, surgical excision, that is wide local excision or colpectomy with or without pelvic exenteration, has been prescribed in the literature. Adjuvant therapy such as radiation or immunotherapy like interferon alpha may be considered, although limited evidence. In advanced cases, palliative chemotherapy or palliative radiation can be used. Sarcoma botryoides. Rhabdomyosarcoma are the most common soft tissue cancers in children and adolescents, accounting for 4 to 6% of all malignancies in this age group. Of them, 20% occur in the lower genital tract and more than 50% are of the embryonal histologic subtypes. The 2013 WHO classification of tumors of soft tissue and bone stratified rhabdomyosarcoma into 4 main histologic subtypes. Most common is the typical embryonal variant, accounting for 58%, and the rest is the spindle cell or sclerosing variant, alveolar variant, or pleomorphic variant. Most rhabdomyosarcomas in children are in the vagina, whereas adolescents have predominantly cervical lesions. Sarcoma botryoides typically presents in the first few years of life, characterized by bleeding and nodular grape-like lesions that fill and may protrude through vagina. In more advanced stages, patient may experience abdominal pain and abdominal mass or symptoms related to distant metastasis. Treatment. These tumors are rare. As a result, treatment is based on case reports and series that has been collected over time. It is recommended that a multidisciplinary team should be involved in decision regarding the treatment, especially when children and adolescents are involved. Ideally, these patients should be referred to Center of Excellence where there has been appropriate experience in dealing with these cases. The current view is that each woman should be treated with a personalized treatment plan by an expert multidisciplinary team. Treatment previously involved extensive surgery, but a series of case reports has suggested less radical surgery. These reports have shown good outcomes in terms of survival as well as quality of life if the patient are selected carefully. Unfavorable factors are such as the cervix being the primary site, large lesion size, and extent of the disease may require radical surgical intervention or chemotherapy. In the absence of these factors, wide local excision and chemotherapy has been used with good success rates. Neoadjuvant chemotherapy is another primary choice that can be used, followed by surgical resection. Radiotherapy should be avoided if possible, as it has long-term adverse effects. Prognosis and outcomes of vaginal cancer. The main determinant of prognosis of the vaginal cancer is the stage of disease or diagnosis, regardless of the underlying histology. So, stage of the disease is the main prognostic factor. For the squamous cell subtype, additional prognostic factor include tumor volume of more than 4 cm, tumor location outside the upper third of vagina, and HPV status and MIB-1 index. As with other malignancies, age, reproductive and sexual function, and performance status can influence the selection of specific therapy and potentially affect survival outcomes. However, the non-negotiable premise is to offer the best option in terms of survival. When comparing histologies, the better outcome is obtained in squamous carcinoma of the vagina when diagnosed at an earlier stage, that is stage 1 or 2. Over the past 3 decades, the incorporation of imaging techniques into diagnosis and treatment planning has influenced clinical decision making, particularly in cases with similar clinical staging but different tumor volumes. As with cervical cancer, the addition of concurrent chemotherapy to radiotherapy has improved survival outcome in patients with vaginal squamous cell carcinoma. Since vaginal carcinoma is a rare entity, most of the available data in terms of therapeutic outcomes come from single institution and include cohorts of patients from different epochs when different treatment modality were used. For example, one of the largest study published by the MD Anderson Cancer Center include 193 patients treated over the 2 decades. This study reported 5-year disease-specific survival rates of 85% for 50% with stage 1 disease, 78% for 97% with stage 2 disease, 58% for 46% with stage 3 or 4A disease. A 2013 retrospective analysis from the Department of Radiation Oncology at Stanford University, drawing on 5 decades of experience, highlighted the positive impact of incorporating advanced imaging technologies such as MRI and PET-CT. These tools have enhanced the characterization of primary lesion, uncovered hidden metastatic disease, and influenced treatment planning. Adding image technique no doubt influences decision making, favoring the use of chemoradiation and intensity modulated radiation therapy, and results in improvement of locoregional control rate and distant metastasis free and overall survival. This is particularly useful in the management of large volume tumors, especially more than or equal to 4 cm, minimizing the grade 3 for toxicities. In terms of prognosis for other histology, young men with early stage DEC related adenocarcinoma treated with either radiation, surgery, or a multimodal approach have good outcomes with a reported 5-year survival in the range of 80 to 87%. This is in contrast to non-DEC related adenocarcinoma, which have a worse prognosis owing to increased risk of both local and distant metastasis. Vaginal melanoma has a very poor prognosis with a 5-year overall survival of 15%. Most of the available literature on sarcoma buttress comes from small case series reported by single institution, often combining various subtypes such as embryonal variant and the tumors originating from different sites within the genital tract. The prognosis was highly correlated with tumor site and histologic subtypes. In rhabdomyosarcoma, prepubescent girls and adolescents, radical surgery did not offer a survival advantage over local excision.